Correct.
Okay. But everybody's still on Kahoot, so we'll go ahead and get started. My apologies. I've used this program a lot of times on your side of it, but I've never been in the driver's seat before. So we're going to jump on in and see how this goes. Looks like we lost somebody. Okay. All right, here we go. Okay, so constriction of the pupil and all the answers we'll go over in the lecture format after this. Anybody having issues getting in or answering?
Yes.
What happened?
I never saw the question.
Never saw the question either.
It's just a bunch of colors.
Yeah.
Oh, okay. So the people that got to answer then are ones doing it on the browser and not on their phone?
I'm on browser.
I'm on browser as well.
And you saw the question and got to do an answer?
I did not.
Did not see the question.
Okay. Let me share my screen, and that way you can read the question and the answers on my screen and then pick the corresponding color. All right. Everybody can see my screen now?
Yep.
Yes.
Okay. Let's try this again. So we'll just not count that 728 points. All right. Okay, good. We got more answers that time. Anybody still having issues? Okay, well, we'll carry on. Dana. 30 seconds might be a little short on this. I thought I made this one a minute. And I don't know how to pause it. Sorry, guys. Right. So this is good. We'll have some stuff to talk about when we go through the lecture. All right. Didn't really change. I don't think anybody got the right one on that one. All right. Right. And this seems like, biochem minutia, but you guys have basic coming up, so I'm pretty sure all this is fair game. All righty. time goes by too fast. All right. I know I did more time on this one. All right, good deal. Good. Very good. All right. Okay, good. Okay. For those that put blue, did anybody say it because it said prevertebral instead of paravertebral? Because there is a distinction, and this answer choice was supposed to say paravertebral. There are paravertebral ganglia that are found from cervical to sacral levels in the vertebral column. That was kind of supposed to be the trick answer that you're supposed to pick, because even though the sympathetic nervous system originates from the thoracolumbar spinal cord, it actually formed prevertebral ganglia from the cervical at the stellate ganglion all the way down to the sacrals at the ganglion empire. But if anybody was thrown off from the paravertebral instead of prevertebral, I apologize. Alrighty. Oh, that is not enough time. I'm sorry, guys. Okay, good. All right, so the three incorrect statements are all true of nicotinic receptors, and the primary receptor for parasympathetic target activity is muscarinic, which is a G protein coupled mechanism. All right. All right, so this next question is going to be the same question, but instead of parasympathetic end organ neurotransmission, it's going to be sympathetic. And I think it's the same answer choices too. So I'm trying to buy you guys a little bit more time since I clearly did not give enough. All right. Good. Very good. All right. I think we have just a couple more. Oh, wow. That's a good one. Yeah, this one was supposed to be tricky. So bronchoconstriction, that is an effective parasympathetic nervous system activity. Increased sweating, that's actually parasympathetic and sympathetically activated. Both can increase sweating. And you can actually have decreased inotropy from muscular receptors as well. Ureter contraction is actually sympathetic nervous system only. This is kind of just a dirty trick question because I'm writing the questions and I can have fun with it. And we have one more question. Hopefully there's enough time. Okay, good. All right. That was a tough one. So, and we'll talk about this when we get to the parasympathetic nervous system, but it's craniosacral. So you do have innervation from all those cranial nerves, but you also have the pelvic splanchnic nerves, which arise from around T12 to L1 out of the spinal cord. Again, the spinal cord only goes down to about L1, L2 in adults. Then it traverses down through the cauda equina and exits out the sacral frame at S2, 3, and 4. But as far as the central origin, it is T12 to L1. All right. Well done, Phipps. Okay, that's enough of this. All right. All right, can anybody see my screen?
Yep, sure can.
All right. Thanks for playing that little game with me. Just thought we'd do something to be a little more interactive since we're so distance and appropriately isolated. I'm James Sweet. I'm the other pain fellow with Dr. Vickers, and we'll be talking about the autonomic nervous system today. I've got a lot of keywords to cover. We talked about a lot of them in the questions. If you have any questions about anything, feel free to interrupt whenever. And every question that I made should be addressed somewhere in this PowerPoint. So let's get started. So that's what we're going to cover today. We're going to talk about the biochemical, molecular, and anatomic aspects of the sympathetic and parasympathetic nervous systems. We're going to talk about a little bit of aortic and carotid bodies, carotid sinus, and go from there. So the first thing we're going to cover is the sympathetic nervous system. This is your classic fight or flight response. All right. So let's talk first about the receptors. The main ones that we're concerned about in anesthesia are alpha 1 and 2, beta 1 and 2. There are beta 3 receptors that do some not really very significant things for us, and there are muscarinic receptors in sweat glands that do respond to sympathetic, and they love to test that. Like, I don't know why clinically it's that relevant, but they love to test that. So the alpha 1 receptor is primarily constriction of arteries, spleen, uterus, all kinds of stuff, mainly constriction. You also can have increased glycogenolysis, increased salivation, lacrimation, that kind of thing. There's 3 subtypes of alpha 1 receptors, none of which we're going to talk about. Those are beyond the scope of this lecture for basic. Then you have alpha 2, which is more relaxation. You do get venous constriction with alpha 2 stimulation, but you get more of the GI relaxation, decreased insulin release, things that you want relaxed when the fight or flight response is going. That's true of both of the two, alpha 2 and beta 2. Then beta 1, again, this is your inotropy, chronotropy, and a couple of other metabolic things. And then beta 2 is your big one for bronchodilation and also for skeletal muscle vascular relaxation to improve blood flow to the muscles. So when you're in this fight or flight, you want constriction of all your blood flow everywhere in the body, basically, except the muscles. So you get more blood flow to the muscles, which is the net effect of all that. So in the neurotransmitters, catecholamines starts with phenylalanine, metabolized L-tyrosine by phenylalanine hydroxylase, which is then converted to L-dopa by tyrosine hydroxylase, and that is converted to dopamine by L-aromatic amino acid decarboxylase, or AAAD, whatever you want to call that. Dopamine is then converted to norepinephrine, or as it used to be called, noradrenaline, by dopamine beta hydroxylase, and then norepinephrine is stored in vesicles, and in the adrenal medulla, it's converted into epinephrine by phenylethanolamine N-methyltransferase. That's your basic synthesis of catecholamines. So the 2 neurotransmitters that we're talking about with the sympathetic nervous system, you've got epinephrine and you have norepinephrine. Both are direct acting. As far as the receptors that they target, epinephrine hits beta 2 and norepinephrine not so much, which is why epinephrine is a good treatment for anaphylaxis when you have bronchoconstriction going on. So epinephrine is primarily a beta agonist at low doses, so you get a lot of that chronotropy and inotropy and that bronchial dilation. When you start giving it in higher doses and higher infusion rates, then you get a lot more of that alpha activity, increased systemic vascular resistance, things like that. It also has some anti-inflammatory effects, which again help for the treatment of anaphylaxis by stabilizing some of these inflammatory mediating cells. And as far as complications, it's somewhat arrhythmogenic. Norepi, when you use a low dose as really any dose of norepinephrine, it's much stronger alpha effect than it is beta. It does have some beta effect, so that when you give it and you increase that systemic vascular resistance, you don't get as much reflex bradycardia because you do have some beta 1 activity, but it's primarily an alpha agonist. half-life really for all endogenous catecholamines, epi, norepi, dopamine is all about 2.5 minutes. Complications of norepi. All pressors are somewhat arrhythmogenic. Norepi is less so than epinephrine. But norepinephrine, you do get a lot of vasoconstriction, pulmonary, renal, mesenteric. So if you prolonged infusion with that mesenteric circulation constriction, you can get dead gut if it's potent enough and strong enough. So you're walking a tightrope when you're using pressor infusions, because you want to increase perfusion of end organs, but if you do too much, then you can actually decrease perfusion of some organs. Norepinephrine is also the postganglionic neurotransmitter of the sympathetic nervous system, which we'll talk about some of the organization here in a little bit. So what do they do? So we've talked about where these receptors are, but what do they do? So in the heart, increased contractility, increased rate. So inotropy and chronotropy. The vasculature, depending on where it is, you get constriction of arteries and veins, but you get vasodilation of arteries and veins in skeletal muscle. In the bronchial tree, you get bronchodilation, and you can read all of these for yourself. They've been listed basically two ways, both under the receptors and under their responses here by organ. And there's another page of these. So the bladder, you get detrusor relaxation, and you get contraction of the sphincter and trigon. The net effect is that it prevents micturition. In that fight or flight response, not the best time to use the restroom. And then you can get contraction of the ureter, again, to kind of prevent the process of urination. And then you can get decreased insulin release in the pancreas, increased lipolysis to mobilize those fat stores, increased glycogenolysis, again, to mobilize energy from glycogen. And you also get some piloerection of your hair from your skin and increased sweat gland secretion. And again, the asterisk on that is that it's postganglionic muscarinic receptors that lead to that sweating response from the sympathetic nervous system. They like to test that. Determination of action, you guys all, most all got this, that it's active reuptake at the presynaptic terminal. So all the norepinephrine is actively taken back up and stored in storage vesicles for future use. Some does escape into circulation via diffusion, which causes, a lot of some sympathetic systemic activity, but for the most part, it's quickly metabolized in the small doses that it's released by monoamine oxidase and catechol O-methyltransferase. So monoamine oxidase, while it's involved in the metabolism of catecholamines, is not involved in the synthesis. I think that was one of the questions. So organization of the sympathetic nervous system. So this is thoracolumbar origination in the spinal cord, intermediolateral nucleus of the lateral cornu, and then it sends axons out via the thoracolumbar anterior rami. And then they form ganglia. There's two types of ganglia. There's paravertebral ganglia and prevertebral ganglia. So the paravertebral ganglia, they're located throughout the spinal column from the cervical to the coccyx, because when these axons come out of the spinal cord, they can do things. They can form ganglia right there. They can ascend to a higher level, like at T1, a lot of them ascend up to form the superior cervical ganglia, or the stellate ganglia. They could also go down. So when you get down to L2, 3, a lot of those go down to form sacral ganglia, like the ganglion impar down in the sacrum. Or the fourth thing they can do is they can transverse through a paravertebral ganglia and go to form a prevertebral ganglia, which is a little bit away from the spinal cord and the spinal column. And there are three of those: celiac ganglia, the superior mesenteric ganglion, and the inferior mesenteric ganglion. So the axons go through those ganglia that are located right on the spinal column, and then they form into splanchnic nerves, and those splanchnic nerves form these different ganglia which innervate abdominal and pelvic viscera. So here is kind of a graphic depiction of that. So you can see coming off of the spinal canal from thoracolumbar origin, they either form a ganglia right there, go up, or go down, or go through to form your other celiac ganglion, superior mesenteric ganglion, inferior mesenteric ganglion. And from there, they project onto their target organs. So why do we care? Well, this is why I care. We'll start with that because I'm a pain fellow. You can have abdominal pain. Visceral pain is mediated by the autonomic nervous system, and also pain from complex regional pain syndrome. So visceral pain sensation. You see this a lot in chronic abdominal pain syndromes. You can see it in malignancy with pancreatic cancer, gastric cancer, pelvic cancers, that kind of thing. You can also see it in non-malignant cases, chronic pancreatitis, gastroparesis, other things like that. And again, visceral pain is mediated by both the sympathetic and parasympathetic. The sympathetic is easier to block, and we'll talk about this when we talk about the parasympathetic nervous system. Is the sympathetic nervous system, those ganglia that form make it to where we can actually block the sympathetic mediated aspects of that abdominal pain by doing celiac plexus blocks. Pain mediated via complex regional pain syndrome, CRPS, not CPRS, which is the outdated computer system used at the VA. There are two main types, type 1 and type 2. Type 1 is from minor trauma, no clear inciting nerve injury, or I like to think of it as a one nerve problem. CPRS is the only nerve issue, type 1. Type 2, you have a history of a major nerve injury. There's a clear inciting injury, or as I like to call, two nerve problems, the initial injury and the CRPS. So that's kind of my mnemonic for separating type 1 and type 2. If that doesn't make sense to you, pretend I didn't say it. Treatment for CRPS, physical therapy is the mainstay. You can also do a lot of anti-neuropathic pain medications or sympathetic blocks. So the lower extremity can be blocked, the sympathetics, with lumbar sympathetic blocks at level L2 and L3, blocking those paravertebral sympathetic ganglia. Or the upper extremity with stellate ganglion blocks, which is, again, that superior cervical ganglia, typically blocked at C6 because you're less likely to hit the vertebral artery there. And again, that is also just the cervical paravertebral sympathetic ganglion. All right, and we're going to talk briefly about carotid and aortic bodies. Carotid body is glomus cells, collection of them at the bifurcation of the carotid artery. Its primary function is to detect changes in arterial oxygen. It also detects PCO2 and pH, but its main one is oxygen. It is innervated, it's afferent, or it's what it sends signals to the brain via is the glossopharyngeal nerve. The nerve of the carotid sinus, or the carotid sinus nerve, is a branch of cranial nerve 9. And its efferent is actually central regulation of breathing. So the importance of this is the main oxygen-dependent ventilatory drive receptor of the body. So if you have patients with chronic respiratory issues who are hypercapnic all the time, your COPD patients whose blood gas shows a PCO2 of 60 at baseline, they could have lost their hypercapnic respiratory drive and could be totally reliant on oxygen for the respiratory drive. A lot of these patients have a PaO2 of 65, because that's usually the threshold for driving ventilation from oxygen. Patients who get a carotid endarterectomy and they remove the innervation of the carotid body, they could lose that oxygen-dependent respiratory drive. So they're much more prone to opioid-induced respiratory failure after carotid endarterectomy because they've lost that oxygen-dependent drive. And then the aortic body, so it's very similar. It's also collections of glomus cells located along the aortic arch. And there's also some baroreceptor cells in there too. Those baroreceptors detect changes in pressure, and they also, the glomus cells, detect chemical composition, pH, PCO2, and PaO2. And again, they're more sensitive to PCO2 and pH, and the carotid body is really just primarily oxygen. Aortic bodies, the afferent is also a parasympathetic cranial nerve in the vagus nerve, cranial nerve 10, and it has the same efferent of the central regulation of breathing. All right, and then the carotid sinus, which is a lot of times confused with carotid body, carotid sinus. So it's just superior to the bifurcation of the carotid in the internal carotid artery, and it's your primary source of baroreceptor information. There is some in the aortic bodies as well, but your carotid sinus is the main player in this. So the afferent is also the carotid sinus nerve, same as the carotid body, which is innervated by the same nerve, branch of cranial nerve 9, glossopharyngeal, that projects to the solitary nucleus of the medulla, which can then activate sympathetic or parasympathetic modulation in a response to the change in pressure, which is why if you give a dose of phenylephrine and you get an increase in afterload, an increase in pressure, the body responds a lot of times with a parasympathetic outflow via this carotid sinus baroreceptor reflex to decrease the heart rate. Same thing when you're hypovolemic or after you induce anesthesia and your heart rate starts going up. A lot of that is because they're hypovolemic, and that decreased pressure at the carotid sinus has that baroreceptor reflex of tachycardia and increased cardiac output. And then real briefly, carotid sinus syndrome is where you're super sensitive to stimulation of that carotid sinus. The classic presentation is fainting while shaving, or if you're not someone who shaves their neck, then just like light touch on the neck can cause a profound decrease in heart rate. And for those of you who maybe confuse carotid sinus or carotid body, I always remembered it sinus pressure. So the carotid sinus is what deals with the baroreceptors, and the carotid body is what deals with the oxygen content. And again, if this mnemonic doesn't help you, please forget that I showed SpongeBob in what was supposed to be a professional lecture. Is everybody still with us?
Yep.
Okay, just want to make sure I haven't been talking to myself for the last however long I've been talking. All right, we're going to press on, finish up with the parasympathetic nervous system, and then we'll be done. So this is your classic rest and digest. Not my dog, but I think it kind of captivates the rest and digest parasympathetic purpose. So we'll start with the receptors. Two main receptor types, muscarinic and nicotinic. They both are responsive to acetylcholine as the neurotransmitter. They were named for whether they were more sensitive to muscarine or nicotine. They are different mechanisms as far as activation. So that one of them is G protein coupling, the other is ligand gated, which is typically a more rapid response. G protein coupling, or with second messenger systems, or ligand gated ion channels.
Ligand gated.
Exactly, right. So it's the mechanism by which we control our muscles. It's switch on, switch off, very quick. G protein is a little bit more delayed, and it has a more longer lasting type effect, not so quick on and off. So muscarinic, basically all parasympathetic post-ganglionic neurons are sensitive or have muscarinic receptors. Sweat glands in the sympathetic nervous system, I know I've said it again, but it'll be on there, have muscarinic receptors. Also, there's some muscarinic effect receptors in the vascular endothelium, which increase nitric oxide production and decrease systemic vascular resistance. The other ones are your nicotinic receptors. These are ones that, when bound, open up ion channels, cause sodium influx, and they're much more rapid conduction of information and messaging. So they're located, all ganglionic, parasympathetic, and sympathetic use nicotinic acetylcholine receptors, which makes sense. You want to get the signal out to the target organ as quickly as possible, and so they use nicotinic receptors. They're also found in chromaffin cells of the adrenal medulla, so those cells that release epinephrine and norepinephrine into the circulation, they're activated by nicotinic acetylcholine receptors. Neuromuscular junction. There's a specific muscle type nicotinic receptor that binds acetylcholine and causes muscle contraction. Also parasympathetic ganglion transmission, both parasympathetic and sympathetic ganglion neurotransmission. There are also nicotinic receptors in the brain that are modulated by nicotine and help explain the addictive nature of nicotine, for what that's worth. So while we're talking about receptors, we'll briefly touch on myasthenia gravis, which is an autoimmune process where the body produces antibodies against muscle-type nicotinic receptors. You get weakness, prolonged effective neuromuscular blocking drugs, high risk of postoperative ventilatory support, treated with four different ways of treating it. You suppress the immune system with steroids or immunosuppressive agents. You give acetylcholinesterase inhibitors, and we'll talk about acetylcholinesterase on the next slide. But basically, that's how the termination of action is accounted for, is by an enzyme, acetylcholinesterase, in the synaptic cleft that breaks down acetylcholine. And if you inhibit that enzyme, then you increase the amount of acetylcholine, you prolong the time acetylcholine is in the synaptic cleft, and even though there's less receptors, you can still get a better effect from having more of it out there. And then the more extreme treatment options, so if you're in an acute crisis, you can do a plasma exchange or IVIG, and then a lot of times they'll come in for thymectomy. So these cases can be pretty challenging. A lot of times they'll come in with a mediastinal mass and a diagnosis of myasthenia gravis with long-term treatment, high-dose pyridostigmine, and a lot of times that it requires sternotomy. Sometimes they'll try and do it with partial sternotomy. Sometimes it's just full-out sternotomy. So these patients are at really high risk for needing postoperative ventilatory support. All right, so back to the parasympathetic nervous system. So acetylcholine is formed by the enzyme choline acetyltransferase. It's then stored in vesicles. So you guys, this is probably pretty much review for everybody, but action potential causes the influx of calcium. That increased charge causes fusion of the vesicles to the cell wall, which releases the acetylcholine into the synaptic cleft. And then acetylcholine binds to the receptor cells. So that acetylcholine is released is the same whether you're talking about whatever receptor it's binding to. And then acetylcholinesterase, which we've talked about, converts acetylcholine to choline and acetate, which are both inactive metabolites. It rapidly clears acetylcholine for that fast offset. Anybody typing on their keyboard, it's really important to be able to have an onset and a fast offset of action. And then acetylcholinesterase, they're inhibited by our acetylcholinesterase inhibitors. We use a lot of these, neostigmine, ribostigmine, pyridostigmine. So what they do is they increase acetylcholine availability in that synaptic cleft, which increase muscarinic and nicotinic activation, which is good. That's what we want to accomplish by them, but there's a lot of side effects that come with that. So you get a lot more nicotinic activation, but also a lot more muscarinic activation. So when we're trying to reverse neuromuscular drugs, if we gave just neostigmine or just ribostigmine, you would reverse the neuromuscular blockade by increasing the acetylcholine available for your nicotinic receptors, but you would also increase the acetylcholine available for your muscarinic receptors. They have not been blocked by your neuromuscular blocking drugs, and so then you'll get profound bradycardia, profound everything muscarinic parasympathetic. So when you're dosing them for neuromuscular reversal, you have to give with an anti-muscarinic agent like atropine, glycopyrrolate to kind of counteract that muscarinic activation that you don't want. So it's interesting when they're given together, they're supposed to have like a net zero effect on your muscarinic receptors. And then a couple other things, some toxins, botulinum toxin. It's really commonly tested. What its mechanism, and it prevents fusion of acetylcholine vesicles, so it prevents them from being released into the synaptic cleft. Causes flaccid paralysis. Somewhat less high yield, but kind of interesting is black widow venom. Works kind of like succinylcholine, causes a release of your stored acetylcholine vesicles. So what do you see from the physiologic response from this parasympathetic nervous system activation? So in the heart, you see decreased heart rate, decreased contractility. Bronchial tree, you see bronchoconstriction. If you think about a lot of these nerve agents that cause a lot of these symptoms, this is where they come from. You get some variable responses in the uterus. GI tract, you get increased contraction, increased peristalsis, so increased GI activity. In the eye, you get meiosis and accommodation. So you get contraction, whether you're talking about sympathetic or parasympathetic. It just depends on what part of the eye you're talking about. Whether you're talking about the circular iris muscles or the linear ciliary muscles. I don't know that it's necessarily within the scope of basic to ask you about the different muscles in the eye, but basically, you need to know that sympathetic causes mydriasis and parasympathetic causes meiosis, and also accommodation is by parasympathetic. And the bladder, you get the opposite effects of sympathetic, which has a net effect of helping you pee, and then you get basically increased secretion, nasal, salivary, and sweat glands all increase in response to parasympathetic activation. So now we're going to talk a little bit more about organization of the parasympathetic nervous system. So the sympathetic nervous system, if you'll remember, forms ganglia paravertebral right there, right next to the spinal column. So you have short preganglionic nerves, they form ganglia, and then long postganglionic nerves that go to the target cells. And for the most part, the uppermost part of the parasympathetic nervous system operates the same way. So here you've got your cranial nerves. There are 4 of them that have parasympathetic nerve activity: oculomotor nerve, facial nerve, glossopharyngeal, and vagus. So 3, 7, 9, and 10. Your ocular motor nerve through the ciliary nerve in your ciliary ganglion helps with meiosis. The facial nerve, both the submandibular ganglion and the submandibular nerve and the pterygopalatine ganglion and pterygopalatine nerve increase your salivation, lacrimation, nasal secretions through parasympathetic activity. And also your glossopharyngeal nerve forms the otic ganglion and the otic nerve, which causes parotid gland-induced salivation. So those first 3 form ganglia and then send out to their target, similar to the way the sympathetic nervous system does. Vagus nerve is different. It's basically, parasympathetic control of your heart, lungs, and the upper bit of your digestive tract. But besides the cranial aspect, you have your sacral aspect too, your pelvic splanchnic nerves. So they originate from the lateral gray horn of the spinal cord, T12 to L1. Again, they travel down as part of the cauda equina and exit via the S2 through 4 spinal nerves. And then they form your pelvic splanchnic nerves, which basically innervate the digestive tract from the transverse colon on. So you get this organization of the parasympathetic where some of it is kind of similar to the sympathetic, but for the most part, it's via the vagus and the sacral nerve fibers, and they form long preganglionic axons. So they do synapse. They do have preganglionic and postganglionic, but they synapse usually very close to their target organ or actually embedded in their target organ. So it's really difficult to block these. You can block the sympathetic innervation of the stomach by blocking the celiac ganglion because they all come together and cluster before they go out. And those postganglionic axons innervate all over the stomach. But with the parasympathetic, you have a long preganglionic axon. So the axon coming out of the spinal cord will go all the way into the stomach itself. A lot of their postganglionic nerve as a cell bodies are actually in the target organ. So vagus and sacral fibers synapse in clusters close to the anatomic targets, sometimes actually within the anatomic targets. So they're not really readily blocked the same way that sympathetic nervous system fibers are. So here you have kind of a picture of how the parasympathetic works. So you actually do have at the top, again, you have these ganglia that form from cranial nerve 3, 7, and 9, and then cranial nerve 10 and your sacral pelvic splanchnic nerves. Again, they go all the way basically to their target organs before they synapse and then have an effect. So for the most part, it's the opposite of the sympathetic nervous system. So for the sympathetic nervous system, again, you have these short preganglionic fibers. They form ganglia right there by the spinal column or just a little bit off in your celiac and your mesenteric ganglia. And then they have long axons that go to the target effect. Parasympathetic, you have those 4 cranial ganglia, but then all the others, their preganglionic axons go out all the way basically to their target organ before they synapse and have their effect. And I think that's it. Anybody have any questions? Okay. Well, if not, sorry I didn't give you guys enough time on the questions. If I ever use the software again, I'll try and put all of them to a longer time. And thanks for listening to me. Well, I'll see you guys around.
Thanks, James.
Thanks for the lecture.